Hello, I'm Dr. Anna Rudolph, and I'm the president of the World Association for Sexual Health. It gives me great pleasure to welcome you to the launch of the official federation of the World Association for Sexual Health in the Middle East region, our new federation, EMFeSH, the East Mediterranean Federation for Sexual Health. So, WAS has a global vision that is sexual health and rights for all. We are a global organization and we have regional federations. And previously, the federation, we had only 5 federations, and the Middle East was only served by a committee within WAS. But now we have realized that this is an important region in the world with unique needs and unique possibilities to add immense value to the global stage and to all of the global tables where WAS can represent itself. And therefore we have asked Dr. Faysal Al-Kak if he, who's been a friend of WAS for many years, who has served on many committees within WAS over many years, and if he can head up a federation in the Middle East. And we are so grateful for what he has put together here today. I'm joining you from South Africa. As you can see, it's warm out here. So I would like to ask you where you are joining us from. And please let us know in the chat where you are from. I will just briefly show you all of our panelists we have here today and to tell you also where they are from. I see here we've got Lebanon, we've got Egypt, we have more Lebanon, people have hot weather, Los Angeles, wonderful. And so on our screen, there you can see Dr. Faysal Al-Kak from Lebanon, Suhaila Al-Fakahani, she is from Egypt, Bouchra Assarag is from Morocco, Rubina is from Pakistan, Sahar from Palestine, Wafa also in Egypt, and Sara is in, at the moment, you're on the West Coast, are you, Sara? But are you representing Iran on the East Coast? You're on the East Coast, but you are representing your country of birth of Iran on this committee, if I'm not mistaken. You know, what I see on this screen here it is bringing tears to my eyes, because what we have done here is to make the impossible seem inevitable in retrospect. You know, to have all of these women from this region on the screen at the same time and bringing the world all of the wealth of knowledge and experience that we have from this era is really making me proud to the core. And thank you, Faysal, for taking the lead, and well done for bringing all of these powerful women with you. And, you know, everything that we do at the World Association for Sexual Health is something that we do as volunteers. So to volunteer more of your time after all of you are already busy professionals is something we are really, really grateful for. I think Sara and Faysal, who's been with WAS for a long time, can testify to the fact that this is a wonderful moment in the history of the world where we have this strong, clear representation of the region. And I always feel that people feel that we need to get Africa at the table, my region, because we have to hear what their problems are. And yes, that is why you are at the table, because the world does want to hear what your problems are, but you are more importantly at the table because you add tremendous amounts of value to the table. So thank you for being at this table. I will go over to introduce you to the inaugural, I think is the correct English word, sorry, president of EMFeSH, Dr. Faysal Al-Kak. He is a clinical associate in obstetrics and gynecology and the director of Women Integrated Sexual Health, the WISH program that many of us know very well at the American University of Beirut Medical Center. He also serves as a senior lecturer in health, behavior, and sexuality at AUB's Faculty of Health Science, and with specialities in sexual and reproductive health and rights. Oh, he doesn't want me to read his whole CV, you know.
We need the time.
That is when you know that a person has dedicated a lifetime to sexual health and rights. That I can testify to, Faysal. So
Thank you.
It's not often that you can literally send one email and say, hey, I think you need to start a federation, and that three conversations later, there's a federation on the table. So thank you so much for your strong leadership here and for dedicating a lifetime to sexual health and rights. And I hand it over to you with pleasure.
Thank you, Elna, very much. And I join you in welcoming everyone from every country, every region, every discipline. We're all in this together. I can see almost 60 participants, and all these participants are with us in this new federation to promote sexual reproductive health and rights, and also to be the strongest voice in this region, along with the others, to really promote and push the issue of justice, equity, and rights forward. And this can't be done. We are starting as you can see on the slide, and as Elna mentioned, these are the presenters today, part of the founding members, but each one of you is a founding member, and also hopefully will be a member to help us go through these matters in this region. You can see the vision, the purpose, and the mission are detailed on the slide, all to point towards joining the effort and really pushing our efforts to promote sexual reproductive health and rights within the context and the specificities of a very diverse region, which is the East Mediterranean region. This region is not one region. This region is full of diversities, as you can see. And in this region, you can see the red color. The red color meaning this is a region with the most vulnerabilities and with the most risks, whether in terms of health deliveries, whether in terms of injustice, whether in terms of conflicts and other problems, which makes this federation more and more needed. The most, of course, recent is the horrible conflict happening in Gaza, and all the lost lives and all the really casualties that are happening there, that has a lot of violations to the rights of the individuals in these protracted conflicts. The East Mediterranean region, as you can see, is a region that's still characterized by patriarchal social structures. However, since ICPD 1994, governments are committed and have been committed to certain achievements to enhance sexual reproductive health and to enhance the issue of gender equity and the issue of rights. In doing this, there are overlapping relations that we as federations and all of us working in this region has to understand. There is a specific context, and that context is very much affected by the socio-cultural factors, by political factors, whether they are political in the governments or politics outside, and also by the international treaties, by the international meetings, international laws. The most important is the SDG 2030. Just a little bit of a background from this interesting paper to show that in this region, and you can see that there is the dark green, there is always this region has darker colors, darker red, darker green, just to indicate that although in the constitution of most of these countries, equality and equity is there, still there are issues where women are not really equal to men in terms of opportunities and in terms of other aspects of the legal, health, and other economic also aspects. And this, what we call cultural relativism and social class, has been an important factor in creating further basis for inequality and for also pushing all these reservations that the government had on signing on many of the international conventions that has to do with rights and justice. And that is one of the most important contextual issues that we have also to join forces and deal with along with the other people. And this disjunction between the discrimination in penal codes and human constitutional rights remain a contested issues until this moment. On the other hand, and because of this contestation in the differences between the constitution, the politics, and the practices, for example, the application of this in terms of sexual reproductive health remains that the links between regulations governing abortion, rape, adultery, incest, battering gender, and SRHR and others, they derive from systems that uphold or upheld male authority and group identity. And that's why women, the physical, the bodily, and the mental integrity is at issue in each set of these rules. And that's why the issue of rights are still denied or still contested because of, at times, commodification of not only women's bodies, but also women's existence within the context or within this within these communities or society. As I said, there is a lot of achievement that has been done. So, like in 1994, the active participation of LCPD, the Cairo Declaration to move forward 2013, 2018, there was a good positive review of progress in terms of policies, strategies, and the programs. And of course, the latest one in Kenya, ICPD 25, again showing really good improvement coming out from this region. These are the lists of the improvements that have been done. I'm listing them here. They're all go to feed into the legal aspects, the policy aspect, and also the health service aspect. But some remain short in terms of the SDG attained goals 3 and 5 and the others, and also remain short in terms of the universal health coverage and gender equity, which is very much highlighted in relation to SRHR in the SDG 2030. These are some of the limited, restricted progress that we're seeing globally and also in this region in relation to maternal mortality, in relation to abortion and the casualties of unsafe abortion, and also in terms of marriages, and also in terms of marriages, I mean the adolescent marriages, and also the FGM. So these are continues to be restricted privileges. If you look at the most recent Lancet review run by led by Guttmacher and Lancet, you see the reality of the matter is that adolescent SRHR is still lagging behind, comprehensive contraceptive care is still lagging behind, comprehensive sexuality education is still lagging behind, safe abortion care and post-abortion care in the context. Advocacy is still lagging behind, and we hope this webinar and many others within WAS are really advocacy for SRHR, and also SRHR in emergencies, as my colleague Dr. Sahar will be talking about the context of Palestine and Gaza. In addition to this, prevention and treatment of gender-based violence survivors, FGM, engaging men, cancers, and lifespan approach are still issues and matters in this regard. So that's why it's very important for us to look at this whole picture. This is a rating, for example, that looks at the legal performance, security for women, and economic performance. And you can see most of the countries in this region are scoring maximum 3.2 and minimum 1.9 over 5, which is we still lag behind in terms of political rights and civic voice, economic rights, and also autonomy and security. That's also part of the context to understand. Also, this is another recent report looking at the issues of gender justice, and you can see all those that are colored in yellow are the reservations that these countries hold against many of the conventions. The most famous one is the CEDAW Convention, meaning we are still really have to do more and more effort with all of you towards the issues related to gender equity, gender justice, and rights. 2024, and we are still having really reservation on many of these matters. This is around sexuality education, and you can see the ones in the gray are the ones related to our region, the East Mediterranean, and this is where you don't have a clear-cut strategy and implementation tools for the comprehensive sexuality education. Again, another gap or unfinished business to look at, in addition to the continued problem of maternal mortality, ranging really in numbers from very favored numbers in the Gulf areas, in Lebanon, and many parts of countries in North Africa, all the way to really very dramatic numbers in some countries in this East Mediterranean region. Likewise, in the issue of contraception, of unmet needs that can reach up to 60% in many places and countries. This is also another report looking at some of the rights in many of these countries. You can see all these lists of rights, and all of these lists related to age of marriage, and this list also that's related to issues of legal ground for abortion. We never had really a very equitable ground for any of these. There are always grades of indications, grades of favoritism, grades of permission in different countries. Again, something to be looking at and working with. So in relation to the issues of sexual identities, little data are still available. I'm talking about the level of the East Mediterranean. Same for the marginalized, for the refugees, and for other issues that also we have to generate more data on this. This is one of the interesting by our colleague and friend Dina Abirafi. Going backward is not an option. And I'm telling you also, with this federation, going backward is not an option. There is a new generation of women who are pushing for equal rights in non-formal, non-traditional ways, and their approach to fighting patriarchal structure is less compromising. I know there is a lot of them attending this webinar today. There is a lot of them in the founding members of the federation, and we are hopeful that we are not oscillating anymore between two poles, the pole of trauma and resistance and the pole of triumph and tribulation. We're going to be staying only on the side of the triumph. This is a very promising recent publication past 2 months by our friend Lina Abu Habib on reclaiming and decolonizing the history of the women's rights and feminist movement in Lebanon. That also will be an excellent resource for our work. We're all invited to join our mission that focuses on advocacy, on creating a forum for sharing expertise, on engaging, on also training, and also creating, all of us, a regional louder voice to promote sexual health and also sexual rights. And thank you very much.
Okay, thank you, Faysal. And I'm very happy to be part of this very interesting webinar to launch our federation. Before I start my presentation, I just want to explain that in our federation, we respect formally our Saharan integrity, Moroccan integrity, and Sahara Moroccan integrity. Don't worry for Moroccan participants in this webinar. Sexual and reproductive health. Sexual and reproductive health rights are universally recognized and as integral components of human rights and essential for achieving gender equality. These rights compass the ability of individuals to make informed decisions regarding their sexual and reproductive lives free from discrimination and violence. They are crucial for encouraging respect of human dignity, autonomy, and overall well-being. in the Eastern Mediterranean region. From our federation, however, this right encountered significant challenges rooted in complex sociocultural dynamic and insufficient public policies. Aside by Faysal, these sexual reproductive health rights are linked principally with human rights from the foundation for ensuring dignity, equality, and autonomy for all individuals. Among these rights are the rights of life, which encompass the right to live with dignity and make decisions that affect one's well-being, including decisions related to sexual health. The right to security guarantees protection from harm, including gender-based violence, which are significant barriers to achieve good sexual health. Ensuring this right is crucial in creating environments where individuals can feel exercise their sexuality and reproductive choice without fear or stigma. The third one, in the right of health, is fundamental to sexual reproductive health, encompassing access to comprehensive sexual and reproductive health care services, and the right to information. And all this, it's related by Faysal before, but we will have more examples, practical examples from our countries. The right to information is essential to make an informed decision about sexual and reproductive health and surmount the misinformation specifically for young and adolescents, and have access to accurate information on poor individuals to understand their rights, options, and responsibilities regarding their sexuality and choice. And in the end, we have the right to no discrimination, is central of sexual reproductive health rights, ensuring that all individuals, regardless of gender, sexual orientation, marital statute, age, or socioeconomic statute, have equal access to sexual and reproductive health services and are treated with respect and dignity. For this human rights, we have the resource as said by Faysal also. We have human rights treaties. In our region, the international and regional human rights treaties, all our countries are signatories to various international human rights treaties. All treaties provide framework for our government to ensure access to comprehensive sexual and reproductive health services and eliminate discriminatory practice. Normally, they are for that, but we will see the challenges about this. National constitution often ensuring principle of equality, dignity, and right to health. This fundamental document can serve as basis for legal protection and policies that encourage sexual reproductive health rights, although interpretation and implementation may vary across different countries and still limited. Healthcare laws. Laws governing healthcare in our countries play a critical role in determining the availability and accessibility for sexual reproductive health services like family planning, prevention and treatment of STI and HIV, and access or no to safe abortion services. And humanitarian law, like now in institution of conflict and humanitarian crisis in many countries in our region, and we have now not something about Gaza. Humanitarian laws, including international humanitarian law, and we say if we practice this, aimed to protect normally the rights of individuals affected by armed conflicts and displaced population, refugees, and migrants. And women rights laws, specific laws addressing women's rights are crucial for advancing sexual reproductive health rights in our region. But implementation and enforcement of this legal framework concerning sexual reproductive health rights can vary widely due to cultural, religious, and political factors. if you say the application of this human right, we can say we can applicate from laws, court decision, policies, and from laws, despite progressive laws, enforcement remains significant challenges. For example, in Tunisia, the 2017 laws on elimination violence against women is often hindered by societal norms and lack of resources, leading to inadequate protection for victims. Also in Morocco, in 2018, we have these laws against violence against women, but the conjugal violence, it's not concerned by this law. Court's decision in Egypt, although the Supreme Constitutional Court has ruled in favor of gender equality in inheritance laws, traditional practice and resistance from conservative factions slow the implementation of this ruling, causing disparities in women's access to inheritance and lack of women empowerment. Policies in Morocco, we have sexual reproductive health aims to promote human rights through the National Strategy of Sexual Reproductive Health 2021 to 2030, but bureaucracies, inefficiency, and disparities can impede its effectiveness. Standard of care, if we say standard of care in Jordan, despite establishment guidelines for reproductive health services, cultural taboos and stigmas surrounding sexual and reproductive health can prevent women from seeking the care they need, leading to underutilization of available care. Provision of care also, Lebanon's healthcare system, strengthened by the influx of refugees, faces significant challenges in providing equitable care. Refugees often encounter barriers such as high cost and limited availability of services, undermining their rights to health. Also, education and training. While human rights education is being integrated in the curriculum, there is a gap in training health providers adequately and the teachers. This affects the quality of human rights and limited the teachers' understanding of patients' rights and responsibilities. This example demonstrates the complex interplay of social, cultural, and systemic challenges in applying human rights in our regions. I want to share with you some challenges in deep. We have 4 kinds of challenges: cultural and social norms, patriarchal norms and taboos surrounding sexuality and reproductive, often limited access to sexual reproductive health, information and services, particularly for women and young people. These deeply noted cultural norms create environment where discussion sexual and reproductive health is considered taboo, leading to misinformation and stigma. Harmful practice, such as early and forced marriage, are prevalent in many communities of our region. Female genital mutilation is another critical issue. The second one, unequal access to health services. Access to health services, including contraception and safe abortion, is often limited among vulnerable population, leading to higher rates of unintended pregnancies with the adolescents, unsafe abortion, and maternal mortality. Financial barriers also, such as the cost of services and transportation, further hinder access. Legal and political framework, like cited by Faysal, many countries in the region have restrictive laws and policies concerning sexual reproductive health. For example, abortion laws are particularly stringent, with abortion being illegal or severely restricted in several countries like our country, Morocco. These restrictive laws forced women to seek unsafe abortion, often in unregulated and dangerous conditions, risking their lives and health. For education and awareness, the lack of comprehensive sexuality education in schools and communities prevent young people from acquiring the knowledge they need to make informed decisions about their sexual and reproductive health. Addressing these challenges, in my opinion, require a multifaceted approach, including legal reforms, improved healthcare services, cultural sensitivity by shifting in societal attitude, and increased resource allocation to ensure effective implementation and enforcement. In this way, I can say that our federation can play an essential role as advocacy for inclusive policies. Our federation works actively to raise awareness among political decision makers of the importance of adopting laws and policies that protect and promote sexual reproductive health rights. For example, advocate the decriminalization of abortion and promote comprehensive sexual education in the beginning and universal access to contraceptive services. The second axe can be promoting research by supporting rigorous contextual research, action research. Our federation contributes to a better understanding of local and regional dynamics concerning sexual reproductive health rights. This research provides essential empirical data to inform policy and practice and promote the innovative methodological tools rights-based. Third axe can be innovative interventions. Our federation, or we do that, our federation promotes and develops innovative intervention to overcome, sorry.
Dr. Bouchra?
Yes.
Yeah.
To overcome barriers to sexual reproductive health rights. For example, it can support the use of mobile technology. Now we have mobile technology and artificial intelligence to provide sexual reproductive health information for young and adolescents, and support digital hackathon of mobile health with adolescents and young proposition concerning sexual reproductive health rights. Also, it's not the last one, but also capacity building. The federation must work to strengthen more the capacity of local civil society organizations, NGOs, and health providers in human rights, gender equality, no violent communication with our health providers, so that they can better advocate for sexual reproductive health rights and offer adequate services to their community.
Okay. Dr. Bouchra, you have the time. You have more the time now. You have 2 minutes more.
And
you consumed.
Okay. I'm afraid about time. Partnership and network. I think that our federation can play central role in our region in the creation of regional and international network with other institutions that facilitate and other not working who works in sexual
we have to conclude,
rights.
Dr. Bouchra.
Mm-hmm.
We have to conclude,
best practice. Okay. To sharing the best practice and the coordinates of offer to promote sexual reproductive health. In conclusion, the challenges associated with sexual and reproductive health in our region are considerable but not insurmountable. Through its commitment to research, advocacy, and innovation, our federation can make a significant contribution to highlighting these crucial issues and promoting effective inclusion solution. By working together, actors in the region, our federation can advance sexual reproductive health rights and improve the liberation and the well-being of population. Thank you.
Thank you very much. You always have a very diverse and rich. That's why you need more time all the time. Thank you very much, Dr. Bouchra. It gives me a pleasure to introduce my good friend and colleague, Dr. Sara Nasserzadeh. Sara is very known globally to all of us. She is a renowned psychologist, consultant, has been working with a lot of agencies over like more than 40 countries, and she has been consultant to many UN and other agencies, and she is the author of several books, and she is a global, always invited to present. But Sara, she is the mother of the federation that we are talking about today. Sara was the chair of the Middle East Sexual Health Committee that really gave birth. Since I'm an obstetrician, I talk about giving birth all the time. She gave birth to this federation with all those beautiful people who are the founding members and other members. So thank you, Sara, for really initiating that chairwomanship back then and really pushing it forward toward this federation, and happy to have you with us today, despite all the time difference across the Atlantic. So thank you, and go ahead.
Thank you so much, Dr. Faysal and colleagues. It's an honor to be here. And Dr. Faysal actually was shoulder by shoulder with me when we initiated the committee, so it's not just me. We can actually move on from this slide. Thank you very much. So, so far, good morning, good evening. This is very early in Los Angeles today, and excuse my voice, I have laryngitis, but I hope that I can carry through with this presentation. So, to bring everything together that we're talking about today, I would like to introduce you to a tool. Whenever that we are talking about advancing sexual health, reproductive health, or rights, it's very important to be first and foremost clear what is the role that we are occupying and what is the impact that we would like to have. This is important because I can give you a lot of examples of how things can go very well and very wrong if you don't really have these clear in your head. There are three roles that I've observed throughout all of these decades of work in this area. One is a role of an activist. Activist is a person who has a torch, who goes around and then says, look, there's an issue here. Here's an issue here. So they steer the pot. They show you what the issues are and they bring them to the surface. They bring them out from the hide. The advocates are the second group that come and say, well, there is an issue. Let's recruit resources to put behind these issues that we have to be able to solve them. And last but not least, there are practitioners who actually go there and execute, do the job, right? So get the job done. The tool that I would like to introduce to you today is this wheel of context for sexuality education. That it's actually, the whole thing is in a book that you can get, but just so that I can get you started with this, regardless of the role that you have of the activist, advocate, or practitioner, you are going to think about the historical background of the place that you walk in, and then cultural, religious, and language of the region, of the country, of the community that you are going to be a part of and you are going to make your impact. The stability versus change. So for example, unfortunately, in the Middle East, change is the stable part of our lives. So even if you invite us to a party that is tomorrow, we say, inshallah, we don't say we'll show up because we don't know if our home will be in place or not. So that's a historical thing to consider, stability versus change. Politics and, and the policies that are around things and legislations. Sometimes in certain countries, you have a policy one day, you recruit your resources all the way, and then a week later, the policy is diminished and the whole resources are gone. So these are the things that are very unique, especially to the Middle East, but also in anywhere else that you're working with within the system. This is helpful to know. And economy. Who is feeding, who is funding, who is withholding the money, where does the money come from, what does that mean, who has the power? Tools and technology, as Dr. Bouchra was talking about, for example, artificial intelligence and access to technology. How can we use it to reduce harm and to increase access for majority of people in the system? So this is one tool that you can use. Again, it's the sexuality education wheel of context. Next slide, please. Thank you. For each of those slices of the pie, there are certain questions that I would like for you to ask yourself before you put down your policies or you even enter a community or anywhere that you really want to work with. So for example, I would like to just narrow it down to the policy slice of that pie that I showed you. What is the current status of the federal and state governments? What are the policies that they hold around sexuality and reproductive rights and health? Are they centralized or are they decentralized authorities that you need to keep an eye on? Who are the decision makers supporting family planning, sexual health, and sexual educations? And who are the opposing factors? Like who and what are the opposing factors? Are there different stakeholders to work with, to ally with? And who do we measure progress with? Like, how do we measure progress? So, for example, in certain situations, reducing the number of female genital cutting would be a measurable progress. In another setting, the fact that they even open the door for you to go in and even deliver the first talk is the progress. So how are we measuring the progress, and in one context? And then what are the competing needs? Right now, colleagues, for example, we spoke about Gaza and the horrible situation there. So imagine that you're walking to Gaza, imagine that you're walking to any kind of a war situation, that there are competing needs, or even not war. In Pakistan, we had flood not a while ago, and we were trying to get resources for reproductive rights and health to the country. It's very difficult when there are competing needs for the air that people breathe, the food that people eat. So these are the things that we can't just have a narrow vision and say, this is what we want to do, and we go in. I highly invite you to really look through the system that you're walking in, whether it's a family, whether it's a community, whether it's a city, country, region, just to see it holistically and have a good strategic plan. Otherwise, it's like a domino effect. When one thing goes wrong, the rest of the system will oppose you. So it's really important for us to have that in the back of our minds. Thank you.
Thank you very much, Dr. Sara, as usual, brilliant and very comprehensive. It gives me a pleasure now to introduce Dr. Wafa Tontawi, who is on the founding members on the behalf of Egypt, but also she works between Egypt and UK. She's a gynecologist and fellow of the Faculty of Sexual Reproductive Health with over 25 years of medical experience. She leads the psychosexual clinic at the NH Trust in London. And also she have previous roles that relate at the Relate Institute, and 10 years of medical practice in many other countries. She brings her experience as a reproductive sexual health expert to the Federation, and also her network in the region and in the UK. Dr. Wafa.
Thank you, Dr. Faysal, and it's my pleasure to be with you today and to be one of the founder of the EMFeSH. And I'm hoping together as a team we'll be able to change things regarding sexual and reproductive health in the Middle East, because we have a lot happening. And I'm glad that Dr. Faysal at the beginning, he managed to portray what kind of problem we have there. And Dr. Bouchra referred to that, and I'm glad that Dr. Sara also referred to the policy making. So from the clinician perspective, I'm going to tell you how clinician can deal with that. Sorry. So I don't think this is my presentation. Sorry. Oh yeah, sorry. I don't know where is the first. My apology. Yeah, so when we talk about sexual and reproductive health, it includes all of that: physical health, STIs, contraception, antenatal, postnatal, sex education, teenage pregnancy, all of that. And that's what we mean by sexual and reproductive health. And actually, it's, as my colleague mentioned, it's a human right. So we look at this picture, which showed us that 225 million of women have unmet needs for modern contraception. And guess what? To achieve good contraceptive for women, all we need is $25 per woman per annum. So the cost is not that high. In UK, for example, every woman needs like 11 pounds a year to get the proper sexual and reproductive health care. So as a clinician, we play a crucial role in providing comprehensive sexual and reproductive health in the Middle East. So there are key aspects of what we can do. First one is clinical care and counseling. We are the front line there. We can also education and awareness, advocacy, as all my colleagues mentioned, confidentiality and trust as clinician. And therefore, it's important to be able to provide confidentiality and build trust with your clients so you can help them. Cultural sensitivity, you have to be aware of that. Training and development for us as clinicians, and collaboration with non-governmental organization and the international organization. Again, my colleagues address gender-based violence, and unfortunately, it's still embedded in the Middle East. And we also can't ignore young people clinic and youth-friendly and research and data to be able to create new things. So I'm going to go quickly through that. I know time is so limited. So we can provide direct medical care, including contraception, antenatal, postnatal, safe abortion where legal, and treatment for all sexually transmitted infection. We also offer counseling on sexual and reproductive health issues, which is essential for informed decision-making. We need really to counsel our patients well, so they can make informed decision, which is, again, is not like something we do in the Middle East. And again, clinicians have to educate patients on various aspects of sexual and reproductive health, including sexual practices, all kinds of contraception, and the importance of regular checkup. We all know that we don't have system in place, for example, for cervical screening or breast screening. We don't have such system, which is very important. And it's important in this region really to be aware of the cultural norm and how it impacts the delivery of clinical care to our patients. And advocacy, as Sara and Dr. Faysal and all my colleagues mentioned, we have to advocate for better sexual health policies and practices within our communities and with policymakers by highlighting the gaps in the services, and also what is the health impacts of inadequate sexual and reproductive health care. It's very important. We can push for changes that improve access and the quality of care. Again, confidentiality and trust. I have to say I'm from the Middle East, as Dr. Faysal said, and I know how the health system works there. Confidentiality is, you can say it's patchy there. Some doctors don't keep confidentiality, and therefore patients don't feel comfortable to open up and address their issues. So we have to discuss sexual and reproductive health with them, but it's a taboo again, because talking about such things is not allowed in the society. And it's important to build our trust with our patients and also to have non-judgmental approach, because still I hear many stories from my clients about that. I went to that doctor, he said that. I went to this doctor, she said that, and all judgmental. It makes them even more fearful to try again to approach any medical professional. And again, it's vital for encouraging individuals to seek care and advice. That's very important. By being there, we need people to come to us and seek help. Culture and sensitivity, as Dr. Faysal talked and all my colleagues talk about it, we know that how culture can impact the decision people make about their medical care. So clinicians must navigate cultural sensitivities and norms when providing sexual and reproductive health services. Understanding and respecting cultural context while promoting health and rights is a key to effective care. It's not about that's the only way or one thing can fit all people. We have to look at our patient each holistically, and each patient is different. Again, we talk about clinicians need ongoing training to stay updated on best practice on all new contraceptive, emergency contraceptive, and treatment of STI. We know that, for example, gonorrhea is really has keep changing its resistance. I mean, the antibiotic keep changing its resistance there. And therefore, we have to keep up to date with the treatment of all STIs and HIV also. And we know that training for HIV and how to help clients to access healthcare in the Middle East is very poor. We don't have such sexual health clinic like in the outside, like for example, in UK, I work in sexual health clinic and we do that as a routine. We provide care for all contraception, emergency, and STI treatment and HIV as a routine thing. We talk also about clinicians often work with non-governmental organizations and international bodies to enhance sexual and reproductive health. This collaboration can bring additional resources, training, and support to local health systems. Again, it's very important to address gender-based violence. And it has many forms. It could be domestic violence. It could be like woman has no autonomy or really treated like second class. And it's very important to do that. And FGM, we can't ignore that because it's still happening, despite many laws happen. In Egypt, for example, we have a law for many years, but still it happens, particularly in the Upper Egypt. So clinicians are often the first point of contact for survival of gender-based violence. So you are the first one who will come and then the patient can tell you. But again, she can't tell you unless she trusts you and again, until she feels safe. And important to ask the question about that. For example, in our sexual health clinics in UK, we have to ask about domestic violence, sexual abuse, any kind of violence. And again, because once you know that, you can provide medical care and psychological support and refer your patient to appropriate services. That's very important. Again, we don't have many clinics where you can refer the victims or survivors of gender-based violence. So this is something as a society, I mean, as a federation, we need to work on. Again, young people, they need services. We have young people clinic, for example, in UK, but in the Middle East, we need to encourage that because developing and providing services tailored to the needs of young people is essential, giving the unique challenges they face during regarding sexual and reproductive health. This includes creating safe space for youth to seek information and care and teach them about sexual and relationship. Or give them sex and education and the relationship education, teach them about many things, teach them about consent, teach them about how they say no and look after themselves. And also use of condoms or whatever they need. They need also a lot of information about sexual health. Research and data collection, clinicians can contribute to research on sexual and reproductive health issues, helping to gather data that inform policy and practice. This research is crucial for understanding local needs and the effectiveness of different interventions. And we know that implementing all of that is not easy. And we know, as my colleague mentioned, so I'm going to quickly run through that there are some challenges there, many challenges, which we are hope as EMFeSH to really overcome them. So we know that we have strong culture and religious belief can restrict open discussion about things. You see, it's still until this moment, I hear people say we can talk about things in Egypt. I'm not talking about UK. I have many clients here and patients, and still they don't know anything about SRH. Actually, even they are very well educated. So we need really to start breaking this culture taboos and resistance to certain services, such as contraception. It's amazing in Egypt, the idea about contraception is very bad. Pills are very bad. Coils can cause infertility. Implant is not good. So all contraceptive here are not good. And actually, we need to educate doctors because some doctors give misinformation about contraception again. And we know that abortion is not allowed in the Middle East, but there are, again, we need to encourage like safe abortion because as Dr. Faysal mentioned, there are many deaths happening for illegal abortion, and it still happens until this moment.
Can we conclude or start concluding? It's
I'm nearly there. So we know that Again, lack of supportive legal framework to protect and promote SRH. And we know that there are areas where there is no services at all, like rural areas. And we know that there are financial barriers. Yeah. And again, probably many things. So by fulfilling these rules, clinician can significantly impact the availability, quality, and acceptability of sexual and reproductive health services in the Middle East, ultimately improving sexual outcome, health outcome. I think we as EMFeSH, we can work with the challenges that obstruct delivery of sexual and reproductive health services in the region. And thank you. Sorry for taking more time.
No, thank you. Thank you very much for highlighting the role and the importance of services and the providers of services in really delivering the comprehensive packages of sexual reproductive health and rights. It gives me the pleasure now to introduce Professor Rubina Suhail. Rubina is a dear friend and colleague. She's a well-established gynecologist, obstetrician, and has a lot of really white hands on the women's health in Pakistan and globally. We worked together in FIGO. She was the chair of the women facing conflict, and she was part of many committees at FIGO that really work towards guidelines, towards policies that really influenced and is influencing now women's health. Rubina, she comes from Pakistan, but her influence is global. And we are very happy that she is one of the founding members of EMFeSH. Dr. Suhail.
Thank you very much. Yeah, thank you very much to us, to EMFeSH, to Faysal, to you especially, for making me a part of this group. And I really wish and hope that I can contribute significantly to this. I just want to reiterate the fact that Pakistan is the 5th most populous country in the world. And being the 5th most populous country in the world, we really have to look at the population of more than 245 million as we stand today. And the important thing about Pakistan is that Pakistan has got a young population. 64% of the population is young, and about 30% of the population or the youth are there. So I was just talking about the fact that Pakistan is the 5th most populous country in the world. It has got a young population, 245 million at this time, the country's population, with 30% youth. The life expectancy is only 70 years, fertility rate is 3.3, and the population doubling time is around 36 years, which is significant. Now, if you look at the maternal mortality of the country, it was in the last survey that was done in 2019, it was 186 per 100,000 live births, and this is huge. And most of the maternal mortality is happening because of postpartum hemorrhage. The currently projected maternal mortality rate for Pakistan is 154. Now, if you look at the fact that the most common causes of maternal mortality are basically hemorrhage, hypertension, abortion, and infection. But if you look at this, the picture on the side, you will see that 29% hypertensive disorders and 41% is basically hypertensive disorders of pregnancy. And these are the major causes of death of the women. Now, the 3-delay model has showed that all the 3 delays in terms of making a diagnosis, in terms of transport and provision of care, are the causes of this maternal mortality. Now, if you come to contraception, and if you look at the situation of the contraception, I would just like to say that the contraceptive prevalence in the last 2 decades or so has not significantly improved. So Pakistan still has a contraceptive prevalence rate of about 30 to 35, in which the modern methods of contraception are low and the traditional methods are high. And if you look at the fact that in the South Asian region, the contraceptive prevalence rate has improved significantly. And if I compare it to the Muslim countries, because in Pakistan, we try to make contraception a religious issue. And if you look at that from the point of view of a religious issue, the neighboring Muslim countries are doing a much better job at achieving contraceptive prevalence rate than is Pakistan. And the Pakistan's program, when it started, was one of the most modern programs. And a lot of other countries actually use that tool to improve the contraceptive prevalence rate of their country. But to Pakistan, it has become static and it is a cause of grave concern. Now, nearly half of all the pregnancies, Pakistan, around 4.2 million pregnancies are unintended pregnancies. And of all these unintended pregnancies, 34% are unplanned births and 54% are going to end up in abortion. And with limited and restricted abortion laws, it becomes a great challenge. So it is estimated that in Pakistan, every year, 2.25 million women are going to undergo induced abortion, and this is an older figure of 2012, and about 6.2 lakhs are going to end up with complications of abortion. This is also a significant number. I know the time is less and the things that I want to say are more, but I just want to quickly go through the gender gap index, which includes economic participation, educational attainment, health, and political empowerment, and look at it from the perspective of Pakistan. That for Pakistan, from the point of view of the gender equality index, is pretty low at only 55.6% in the region. And if you look at the economic opportunities, 31%, education 81%, health 94%, and political power only 15%, and this is significant. Now, this was published in Dawn, one of our newspapers, a couple of years back, and it was a cause for concern. But if you look at the countries whom we like to call developed and in whom we think that gender equality exists, Western Europe is going to take 52 years to become gender equal, Latin America 68, Northern America 61 years, MENA region 140, more than 140 years, and for our portion, it is 195 years if we look at South Asia. So gender equality is one of the basic ingredients for achieving the sexual and reproductive health and rights, and that is something on which we need to think. I just want to share quickly with you what is happening to women in terms of education, in terms of governance in Pakistan. So in our political allies, and in politics, you will see only 20% women. Chairperson of standing committees, only 44% women. Ministers in provincial cabinet, only 5% women. So in education, only 57% of women are practically educated, and there are a lot of women who are out of school and who are suffering because of lack of appropriate education. In economic participation opportunities, women are only 26% of the labor force, and many of them probably are not being even registered as a labor force. If you look at economic participation and opportunities, and if you look at their ownership and physical resources of land, only 1.9%. Bank accounts, even for a female, are only 32% women have got bank accounts, and this is probably an improvement from the last 10 years or so. Now, similarly, you look at the beneficiaries, and this is the beneficiaries that the government is trying to create. They are doing much better than the general population because the government is. Regarding justice, domestic violence has decreased only 3%, sex crimes only 2.8%, acid burning decreased by 38%, and this is by the interventions that the government has done to improve the justice for women in Pakistan. Now, if you look at the fact that whether they are judges in the High Court or in the judiciary or not, only 5% of women are judges in the High Court, and we are very privileged that we have a judge in the superior courts at this point in time. And my talk will not finish unless I talk about gender-based violence. And these are all pictures of gender-based violence in Pakistan, whether they are adults, adolescents, or children. All of them are there. And I would just like to say that more than 1/3 of women, 2/3 of women in Pakistan have experienced some kind of physical, psychological, or sexual violence in their lifetime. And the most common partners are the intimate partners who are responsible for this kind of occurrence. And the government is doing quite a bit of work. Now, genital mutilation, child labor, and child marriages are all responsible, but genital mutilation is the lesser of the troubles for our area. But child labor, child marriages, and adolescent issues are at the top of the list for our youngsters. And adolescents, as I said before, are more vulnerable. Our legal age of marriage is only is 18. Is 18 years of age, and the Pakistan government is basically trying to change the legal age of marriage. So to conclude and to finish within my allocated time, I just want to re-emphasize and reiterate that the role that EMFeSH can play in promoting sexual and reproductive health and rights in the region. I think it's a four-pronged strategy that could take place in terms of improving education, advocacy, improving healthcare access, giving greater role to the healthcare providers, and the healthcare providers taking up the role of policy advocates and talking to the government and playing much more importance to community engagement than we do at this point in time. And my last message is that I feel that the environment must change and we must think of a gender equal world. Unless we create a gender equal world, the sexual and reproductive health and rights can be a dream but cannot become a reality. Thank you very much.
Thank you very much, Professor Suhaila, Professor Rubina, for this amazing presentation and for all the work really you're doing in this vast country, Pakistan. It's really something very impressive. It's not strange to you to do really great work, and the recommendation that you have in the last slide are definitely, with your help, gonna be at the core of the work of our EMFeSH and our federation. It gives me a pleasure next to introduce the really dynamic coordinator of the EMFeSH, of this federation, Suhaila Fakhani, who really been putting a lot of energy trying to connect all the dots and bring in all the energy together into this federation. Suhaila is the youngest in the existing members. Hopefully you'll have younger people coming in. ما حتزعلي. She's a social researcher, medical anthropologist, and a sexual reproductive health and rights specialist. She holds a master's and a bachelor from the American University of Cairo. Currently, she is working on multiple fronts. She is working on a sexual reproductive health research project funded by a DRC at the American University of Beirut. And also she has worked before in a project related to sexual reproductive health and violence under conflict among refugees. And she is also be working on a project around the menopause. She's very busy around the research agenda. And we are very happy to have Suhaila with us as a founding member. Thank you, Suhaila, and please go ahead.
Thank you, Dr. Faysal. Hi, everyone. Good morning or evening, depending on where you are. It really is a pleasure to be here, focusing specifically on engaging youth in sexual and reproductive health and rights advocacy, which is the base of my work and each of us work. At EMFeSH, we're also always trying to bring in new voices, experiences, and expertise that would help us bring our vision to life. Can I please have access to the presentation? Yes, thank you. So the first thing we want to talk about is why youth engagement matters. As Dr. Rubina mentioned, not just in Pakistan, but the East Mediterranean region as a whole is known for having a big cohort of youth, more than Europe, for example. And the idea of demographic significance is that the youth are at the heart of any progress, not just because of the innovative perspectives and the idea that they can bring in fresh ideas and bring in clear and newly heard voices, but also because they make up most of the populations that we're talking about. The second thing we need them for is that they can also be able to identify gaps and needs that they need and that will then enhance and improve the sexual and reproductive health and rights of the next generations to come. The third thing is sustainable impact, because it ensures the long-term sustainability of the initiatives that we're trying to work on. The younger people are involved, the more it's likely for them to grow up in a space where they are advocates and they are raising awareness for sexual and reproductive health and rights issues that they both go through, but also that their peers and the people around them experience, which then makes their own experiences as person-centered as possible, but also sustainable for the long term. Yes. The current sexual and reproductive health and rights landscape in the East Mediterranean region is involved in all of our presentations, whether it's talking about policy or clinicians' roles, or even the overview Dr. Faysal mentioned, shows that the coming of age of youth and adolescents in the region is marked by taboo and shame, and the cultural norm that views these topics as non-negotiable. And what we have actually is the no sex talk. What we have is that families, friends, and even teachers try to neglect and often create this intentional ignorance for the youth and the adolescents to have the power in their hands, to have their self-agency and bodily autonomy ensured, and for them to know their own rights when it comes to, for example, seeking sexual and reproductive health and rights services, which is often hindered by things that relate to marital status, age, who you're going to the clinic with. All of these aspects that have to do with the social and cultural relevance of their own seeking of the service is most of the times a big problem when it comes to accessing sexual and reproductive health and rights, not only services, but also resources and knowledge. Socioeconomic barriers also create a big problem for young people when it comes to sexual and reproductive health and rights, because if they can't afford the clinic they're trying to seek help from, and they don't have the support, for example, from the family or friends for them to seek the help they need, they more often than not just ignore their issues and just go on the internet, which most of the times results in unreliable information being taken by these young people and spread to other friends and even family members who are young. Other challenges also include conflict zones. We also know that Palestine has a huge number of young people on the ground who are also facing daily sexual and reproductive health and rights issues that relate to safety and security and even basic human rights. That being said, we have opportunities when it comes to the youth in sexual and reproductive health and rights, because globalization and the moment we are in, where everything is interconnected when it comes to the online sphere, it's created opportunities for youth and individuals to create awareness, create regional collaborations, and even seek global support. Today, we see on the rise a lot of platforms and a lot, even the WISH program that Dr. Faysal very greatly leads, is a platform among many platforms that are created from and for the youth to understand and really get the idea that their body and choices and knowledge that they have about their sexual and reproductive health can be their own. Regional collaborations are also taking place, where we see projects such as Masaruna and many other projects that connect different countries from the region when it comes to youth sexual and reproductive health and rights. What youth can do when it comes to sexual and reproductive health and rights varies. They can be advocates that raise awareness and push for policy change. They can be peer educators and provide accurate information and education to their peers. They can be researchers and conduct studies to highlight youth-specific sexual and reproductive health issues that can then translate to policy change. And they can be leaders in their own organizations or in their own initiatives that they are passionate about, in order to also improve sexual and reproductive health and rights in their respective countries. One of the most important things we always discuss and is on top of our agenda in EMFeSH is comprehensive sexuality education, because we truly believe that this is where it all starts. This is where it all starts because it's fundamental to advancing sexual and reproductive health and rights, equipping those young people with the knowledge and the skills they need to make informed decisions about sexual and reproductive health and rights and decisions and their own bodies is always in the center of creating new generations that are aware and that are able to create change that maybe previous generations were not able to do as straightforward or with much control. And a holistic approach to comprehensive sexual education has been always reiterated and created and recreated. But what we actually need is for it to cover a range of topics that include relationships, gender equality, sexual orientation, consent, and contraception. This idea promotes a holistic understanding of the self and sexuality, which helps with the myth busting, which is one of the biggest issues we have to work with, especially for the youth, is to relearn and unlearn ideas about themselves and sexuality and sexual health that they have always had in their minds from unreliable sources or from experiences that have not been very positive in their upbringing. So dispelling myths and misconceptions is one of the top things we need to be working towards, and what we're working towards, how we're working towards it is comprehensive sexuality education that empowers agency and bodily autonomy with a focus on making the right decisions. We then move to the bigger picture when it comes to policy and decision making. When we talk about policy, we always think big, we always think governments, we always think big stakeholders, but we also need to understand the inclusivity and representation one should have in mind when it comes to including the youth in decision making. They are not just the leaders of tomorrow, but they are active change makers of the day we are in today. Most of the organizations we talk about and most of the initiatives that are happening are most of the time built by and from and for youth. And that's what we're trying to work with. Even Dr. Wafa mentioned the idea of youth-friendly services or youth-friendly clinics that are lacking in our region. It's not just about the clinics and just about the idea of going to get service and just having the adequate service only, but it's about the idea of being represented, because once you represent and hear the voices of the youth, you can really identify their needs and the gaps that exist on the ground for the fresh perspectives and innovative solutions to come to the table and actually show themselves and others how these experiences can challenge the norms that we have today and the whole idea of cultural and socio-political and religious norms that keep creating and recreating themselves to suppress sexual and reproductive health and rights from being on the table of discussion when it comes to policy can be changed when we give the adequate sources and tools for youth to engage in the conversations that have to do with sexual and reproductive health and rights. The way forward, honestly, in EMFeSH, we are keen on including more young voices and bringing their experiences and expertise and passion to the table. We're trying to prioritize their engagement, to create collaborations, to work on capacity building for trainers of trainers, and to have partnerships with already created institutions and organizations that work with and from and by youth, in order for us to be able to create a space where we have the medical and the biomedical and the approaches that have to do with so much research and work that has been on the ground, but we're also still open to hearing and taking into consideration and actually putting in the forefront the engagement of youth that is essential for advancing sexual and reproductive health and rights, especially in the East Mediterranean region, because once we give them the voice, they can be the new faces that create a future where sexual health is respected, protected, and fulfilled. Thank you so much. I'm looking forward for your questions and discussions at the discussion.
Thank you very much, Suhaila. Brilliant, as usual. And definitely, we can see the passion for youth inclusion. I can't but agree with you on this important aspect of the Federation. It gives me a great pleasure to introduce a really long-time friend, colleague, collaborator, Dr. Sara Hassan. Dr. Sara is an associate professor of nursing and the former dean at Birzeit University in West Bank in Palestine. She has a PhD in women's health from Oslo and a master's in nursing midwifery from UPenn, and she has been really engaged fully with the women's health issue, focusing on maternal neonatal health through the MedRed project to enhance the quality. She has been working with a regional group. We sit together in a regional research group. She is involved in academic work, research work, and also in community work. And she is involved in many committees, academic boards that all witness and testify to her commitment to women's health and community health, especially in a land which is really impacted by conflict like Palestine. Dr. Sahar.
Thank you. Thank you so much, Dr. Faysal. Thank you for joining us, and it's a pleasure for me to join you all on this important webinar in our region. I will be talking about the sexual reproductive health and rights in conflict situation, and I will be focusing on Gaza, situation on Gaza. So I will start talking a little bit about the context of Palestine, just giving a snapshot about the land, the population, and some indicators related to sexual reproductive health. Yeah, it's working. So Palestine constitutes of 3 areas that are not geographically connected, and that constitutes what we call the Occupied Palestinian Territory, or the OPT. And these 3 areas are Gaza, West Bank, and East Jerusalem. We are about 14.3 million Palestinians scattered in historic Palestine and diaspora, living around in Palestine, Arab or foreign countries, or 1948 territory, and 44% of Palestinians in the OPT are refugees. If we look at Gaza, Gaza is a small strip on the Mediterranean Sea, as you can see, a land of 365 square meters that is known to be the most densely populated place in the world, because there is around 2.3 million people living on this small area. 40% of these people there are from age from 0 to 14. Looking at the general and sexual reproductive health indicators in Palestine, we are doing fine in terms of maternal mortality, under 5 mortality rates, and neonatal mortality compared to other neighboring countries. However, we are a young population in Palestine. 38% of our population are young. Average household is about 5.1, with higher numbers in Gaza, and fertility rate is a bit low, but it's still considered high compared to other countries in the region. And C-section rate is about 28, which is also considered high compared for the state like Palestine. We have some challenges, and we have been suffering from many challenges related to sexual reproductive health and the healthcare system in general before October 7th. And I will just talk about 2 examples of these challenges that we have been suffering from for many years. One is related to the health system. The healthcare system lacks lots of sufficient infrastructures, including shortage of drugs, medical equipment, supplies, electricity, and water, which is beyond our control, which has affects hospital service and our daily life. So this is number 1. And number 2 is the restrictions of movement and travel and access between cities, and between the West Bank and Jerusalem, and between Gaza and the West Bank. And if you can see in the photo, this is how people in Palestine cross from one city to another, or cross from the West Bank to Jerusalem. And Jerusalem, there are many hospitals there, specialized hospital, where Palestinians are always denied the permits to travel there, even to get treated. Talking about Gaza after October 7th, and I'm showing you the photo of Islamic University in Gaza before October 7 and after October 7. And now some 1.9 million people, or more than 80% of Gaza population, have been displaced. And we know that thousands of people there have been displaced more than once, up to 6, 7, or 8 times. This is some of the key figures from Gaza, the latest that were published by UNFPA in July 2024, and gives you an idea about fatalities, injuries, internally displaced, and so on. If we look here, for example, there is about 28,000 pregnant women there are suffering and experiencing emergencies and catastrophic situation. About 15% of these women will be suffering from unmanaged complications during pregnancy and childbirth, which can lead them to indirect causes of maternal death. And also birth will be under unsafe conditions, because number of hospitals is it's only 3 maternity hospitals there, and they are partially functioning in terms of birth. So we know about cases of birth unbearable or intense. Midwives and physicians there in Gaza, they've been reporting high miscarriages cases by 300%, increased number of premature births by 1/3, and increased number of stillbirth and congenital anomalies. Pregnant women, they suffer from malnutrition, dehydration, and anemia, and around 155,000 pregnant women and breastfeeding mothers, they are struggling to survive. They are exhausted, they are traumatized, dehydrated, and facing starvation. Also, above all, we have 690,000 menstruating women and adolescent girls there that they have limited access to menstrual hygiene products and WAS. And women are very much exposed to gynecological infections, sexual and gender-based violence. Family planning methods are not available. And if there are few methods that are available there, they are irregular and insufficient. There is a collapse of health system and sexual reproductive health and GBB services there. I would like to play this video giving an idea about life-saving of women in Gaza crippled after 200 of the war. Can I have the video, please? Can somebody help me to play the video? You need to play the video.
That remains of Shifa. I'm here standing in Shifa Hospital and heartbroken at the scenes that we're seeing, the dust that remains of Shifa Hospital. Behind me is the maternity hospital. Now, before October, the 180 births every day happening in Gaza, the complicated emergency obstetric care cases in Gaza City would be referred here. Today, it stands empty. And right now, 2 kilometers away from here, the Sahaba Hospital is the only place that's enabling to give life in Gaza City right now. Now, with the World Health Organization, we're looking at how we can support the re-establishment of Shifa Hospital, because this maternity hospital should be a source of hope for the future. But right now, it's the sign of death and despair.
Okay. So this is an example of one hospital there. This is an example of one hospital there in Gaza that has been totally destructed. If we move to the West Bank, the situation is not much better because violence and aggression continues silently there. So there is forcible displacement there, worsening long-standing patterns of violence, daily searching and arresting and aggressions to towns and cities and camps, using lethal open fire policy against everybody. Also, Palestinians in the West Bank, they are suffering from their physical conditions there. No. Okay, so in summary, in Gaza now, I need the one before. Okay, in Gaza now, no place for safe living anymore. Everywhere, civilians risk dying from air, from sea, from ground, from disease, and from starvation. Women and children in Gaza need food, water, shelters, protection, healthcare, and treatment, and must be able to give birth safely and with dignity. This is 100 man-made catastrophe that was entirely preventable. An urgent action needed or to conclude a ceasefire, a complete ceasefire is needed urgently, and the world should stand united on the urgent needs to protect civilian Palestinian population, both in the West Bank and Gaza. Border crossing and corridors must be fully open to allow all necessary humanitarian aids to reach the people in Gaza. And EMFeSH would advocate and collaborate with other humanitarian agencies to help women and children in Gaza. And thank you so much for listening.
Thank you very much, Sahar, for this intense, overwhelming presentation. And unfortunately, the world is still watching these atrocities against the Palestinian and the innocent people. I hope with your help and with the Federation, we can stand up for the rights and the dignity and the equity in Palestine and the people in this region. I want to thank all our speakers. I want to thank all those that attended, and hopefully they can be part of this federation. I want to thank the Mother Association, the President, Elna, and also the team that really helped us made this possible. I will pass it to Suhaila before we conclude with Elna, our President, and thank you again, everyone.
I'd like to thank everyone again for being here. And as we conclude, it is very evident that the establishment of the East Mediterranean for Sexual Health marked a significant milestone in the collective journey we're all on as individuals in trying to advance sexual health and rights in our region. The presentations highlighted the interconnectedness and achievements and the gaps that persist in achieving and promoting sexual and reproductive health and rights, in addition to the region's need to align more closely and directly with global strategies for improvement of SRHR. The Federation also aims to come in as a platform and a regional voice to represent, promote, and help assess collective advocacy, knowledge exchange collaborations, evidence-based and contextualized policy change, capacity building, and new and innovative interventions and programs. Our vision of universal access to sexual health and rights is ambitious, yet we think it's achievable through dedicated advocacy, partnership, and knowledge exchange. In tying together the themes and insights from today's session, it's become clear that a comprehensive, culturally informed, and person-centered approach is crucial. With this approach, it respects and promotes human rights and ensures that every individual's dignity, health, and well-being are at the forefront of our efforts. We'd also like to extend the invitation to invite you to join our federation and reach out to us via email. I have it on the screen, but it's also in the chat. And we have now the time for discussion and questions, but we first have a word from Dr. Elna was as president.
Thank you so much, Suhaila. Unfortunately, we are out of time for questions. We will not be able to take them here. We invite you to please connect with the Federation through their email address and through their website. Suhaila shared the details here in the chat, info@emfesh.org, and the website is emfesh.org. And that leaves me to thank the panel for their extremely insightful contributions to this very rich webinar. Thank you to each one of you for sharing your passion primarily. And I think you will go down in history as the mothers of this organization that will change the course of sexual health and rights in your region. And may God be with you, and thank you very much for what you have done. On behalf of the World Association for Sexual Health, we thank you for taking the lead in that region and bringing sexual health and rights to all. You've got our full backing and support. I would like to encourage everyone from your region to give your support to your federation, and we look forward to seeing what's coming hereafter. Thank you again to all of the speakers and for all of the arrangements. Faysal, thank you to you, Suhaila, for making the arrangements, and we appreciate it. Goodbye.